Hello, everyone, and welcome to ADDitude Magazine's ADHD Experts broadcast. We hope everyone is staying safe and staying well. We are pleased to have Dr. Tumaini Coker here to talk about equity in ADHD care, improving diagnosis and treatment among Black and Latinx children. Before we get started, let me note a couple of housekeeping items. Those of you tuned in to the live webinar may download the slides now by clicking on the Event Resources section of your webinar screen. And if you are interested in the Certificate of Attendance option, look for instructions in the email you receive around an hour after the live broadcast. For those of you listening in replay or podcast mode, you can visit ADDitudemag.com and search Podcast 352 to access the slides, the webinar replay, and the Certificate of Attendance option. And if you support the work we're doing here at ADDitude to strengthen the ADHD community, we encourage you to visit ADDitudemag.com/subscribe and sign up for ADDitude Magazine for your family or to share with a teacher or a loved one who could benefit from greater understanding of ADHD. Now for today's topic. Clinicians and parents are increasingly recognizing the inequities in ADHD care for Black and Latinx children. Children of color inadequately treated for ADHD face serious consequences at school and experience long-term negative impacts on health and well-being. Dr. Coker will address these diagnostic and treatment disparities, the negative impact of these inequities, and how the medical community can adapt parent behavioral training programs to help meet the needs of these families and achieve equity in ADHD care. Dr. Coker is Associate Professor of Pediatrics and Chief of General Pediatrics at the University of Washington School of Medicine. She also serves as Director of Research at Seattle Children's Center for Diversity and Health Equity. Her research focuses on community-engaged design and evaluation of innovative interventions to reduce socioeconomic disparities of care among children, and on primary care practice redesign for children in low-income communities. Dr. Coker practices primary care and teaches medical students and residents at Seattle Children's Odessa Brown Children's Clinic. You can ask questions during Dr. Coker's presentation, and we will get to as many of them as possible after she finishes. So with all that being said, I'll turn it over to Dr. Coker. Thanks so much for being here today.
Thank you for having me. It's wonderful to be able to share some of these ideas with you, and I look forward to really having a fruitful Q&A session towards the end. So I'm going to start with just some disclosures. I have no financial disclosures of conflict or conflicts of interest to talk with you about. But I have 14-year-old twin boys who have ADHD. And my interest, my work, and my concern for equitable care for children of color with ADHD has been informed by my own family's experiences with the diagnosis and treatment and progress, as well as the families that I see every day in primary care. So with that, I just want to really quickly talk about what I hope to cover in the next 35 to 40 minutes or so. I'm going to talk about why these disparities in ADHD really matter, and I'll use the school to prison pipeline to talk about that. I'm going to talk about what we can do to improve equity in care, and I'll focus on behavioral parenting training, specifically focused on African American families. And then I'll also talk about what is known about disparities. What are the other factors that can lead to inequities in care? So we'll start off with this question about why the disparities matter at all. The problem we all live with, that is the title of this well-known Norman Rockwell painting. It shows Ruby Bridges, the first Black child to attend all-white elementary school in the South. And she's walking in this picture into a newly desegregated school under the protection of 4 U.S. Marshals. Over 40 years later, when this image has been reimagined, here we see a Black child in school surrounded by police officers. But here they have a different role. It's not a protective force, but it's more of an imposing sense of policing in schools. And I want to talk a little bit more about that through this idea of the school to prison pipeline. So the school to prison pipeline describes a process in which harsh disciplinary policies at schools can lead to pushing children out of the educational system and into the juvenile justice system. The overly harsh discipline of behavioral concerns at school includes strict enforcement of zero tolerance policies, suspensions and expulsions at school, even the use of school resource officers that include law enforcement for just problem behavior at school. As an example, a behavior such as talking back to a teacher, it can be interpreted as intimidation. And that can lead to criminalization of a child behavior in a school that would have otherwise led to a trip to the principal's office or detention at recess. Now, these behaviors have been approached with school suspensions, with expulsion, and even police arrest. And there's ample data from around the country that Black students are more likely to be placed in this school to prison pipeline than white students. So Black children are disproportionately impacted by school suspension, way out of their proportion to the numbers that they have in the school system. They're suspended and they're expelled 3 times more often than white students. And when they are suspended or expelled for behavior, they're almost 3 times more likely to be in contact with the juvenile justice system in the following year. So it has severe consequences. And there are other populations who are even more at risk. While Black boys are 3 times more likely to be suspended than white boys, Black girls are 6 times more likely to be suspended than white girls. So here I want to share with you a graph from a report for the Center for American Progress from 2018, analyzing the prevalence of suspensions and expulsions amongst children ages 3 to 5. And it shows a disproportionate use of suspensions and expulsions for children with disabilities. And this actually is at the preschool level. So let's first look at behavior problems. So these children with behavioral problems make up 4% of children in the preschool population, but 71% of children with a preschool suspension or expulsion. Now, children with ADHD at this young age are just 2% of the population. And these are right down here. You can see this in this graph here, if you can see my cursor. So just 2% of the population, but they're 53% of the preschool suspensions and expulsions. So harsh discipline at this early age for just behavioral concerns in preschool is particularly problematic, since the children who are at higher risk for this type of discipline, Black children, Latinx, low income, those with disabilities, these are also the children who are more likely to experience multiple adverse childhood experiences because of their circumstances. And those experiences may be manifesting as the behaviors themselves that they are being punished for. So what are these children getting suspended for? This is from the Seattle Times, who came out with an analysis of this topic. And they looked at data from the 2013 to 14 school year among Seattle elementary school students. And here you can see that the number of students suspended in that school year for certain behaviors are listed. And if you look, let's say, at disruptive conduct, which is 3 rows down, 87 students were suspended. 52% of them were Black, 24% were white. Let's look at disobedience. We have 44% of that, those students were Black, 25% of white. Interfering with school authority, 50% Black, 6% white. And so why does this disparity in suspensions matter beyond a child being suspended for school? Well, out-of-school suspensions have serious consequences for the children. Nearly half of high school students with 3 or more suspensions drop out of school. And youth who are suspended or expelled for school are 3 times more likely to be in contact with the juvenile justice system in the following year. And sadly, we know what the juvenile justice system looks like in the United States. So even though this pictograph tells us that African American children comprise 16% of the population of youth in the U.S., they also represent 26% of juvenile arrest, 44% of those who are detained, 46% of youth sent to criminal court, and 58% of those admitted to a state prison. So the proportions are just horrendous. There was a meta-analysis that looked at the variable prevalence of ADHD in incarcerated populations. And what this group, led by Young et al., found was that ADHD prevalence was higher with diagnoses for screening versus diagnostic interview. They included retrospective diagnosis and looked at current diagnosis. But overall, they found that 30% prevalence of ADHD in the juvenile incarcerated population and 34% in the adult. Now, Monique Binkin and colleagues wrote a paper linking early ADHD to adolescent and early adult outcomes among African Americans. And so they were interested in this question: can ADHD lead to adult incarceration among African American youth? And so they hypothesized that per the school to prison pipeline that we've been discussing, that ADHD symptoms would be interpreted as school behavioral problems in Black children. Now, then these behavioral problems would be associated with negative teacher ratings and lower standardized test scores, which would in turn predict more suspensions and expulsions and juvenile arrest in adolescence. And then these adolescent experiences would then predict arrest in adulthood. So they tested this hypothesis. So they focused on African American children with ADHD and used a sample of 889 children participating in a longitudinal study of African American families, both in Iowa and Georgia. The children were ages 10 to 12 in enrollment, and the study started collecting baseline data in 1997 to 1998. They continued all the way through 2008, following the youth and their families. Now, the diagnostic interview schedule for children, version 4, was used for ADHD diagnosis at ages 10-12. And then they had the teachers complete the child behavior checklist teacher form. And they also had state test scores as well in their data. So this is the hypothesized mediation model for that school to prison pipeline. And the correlations are indicating how what the association is for each step of the model. And basically, I'll quickly go through it, but the findings were consistent with their hypothesis in that a diagnosis of ADHD here in childhood then predicted worse teacher ratings of behavioral problems here, worse standardized test scores, and then we can see the expulsions and exclusionary disciplinary and juvenile arrest here, and adult arrest. So that is really why what we do for kids in school, particularly when they have problem behaviors and we don't appropriately diagnose and treat ADHD, because of the way that Black students and Latinx students are their behavior is interpreted in school, can lead to really dire consequences for their well-being moving along. So now I want to go to the second question around what can we do to improve equity. So I'm going to start by just quickly discussing the multimodal treatment study of children with ADHD to really set the stage for this. So this started as a randomized trial of 579 children ages 7 to 9, and they were randomized to 4 different groups. receiving 14 months of medication management, behavioral treatment, a combination treatment, or standard community care for ADHD. Now, the primary results of this trial were published back in 1999, but since that initial trial, there have been numerous follow-up studies and analyses that really defined what we know about ADHD. So in an analysis of the data by Arnold and colleagues that was published in 2003, they published a paper looking at what were the effects of race and ethnicity on treatment outcomes at that 14-month outcome. And to do this, they matched each African-American and Latinx participant with a white participant by gender, the assignment group for treatment, and then the actual site, the clinical site, to understand whether and how the treatment effects differs by child, race, and ethnicity. But they had three main findings that they found. First, the response to medication was not different among white, African-American, and Latinx children. Second, the addition of behavioral treatment in addition to medication management is likely really important for children in low resource and low income settings, particularly when those children are Black or Latinx. And then the third finding was that the parent and teacher ratings of the child's symptoms often didn't match as well for African-American Latinx children as they did for white children. And that's not so surprising as we think about the data that I just presented in terms of the interpretation of behavioral problems in school for Black children in particular. So this, brings this next point in that really ensuring high quality treatment programs that include medication and behavioral treatment is really important for better outcomes for these children. And the addition of behavioral treatment may be even more important for African-American and Latinx children. And so within this idea of behavioral treatment, I really want to focus on parenting training. In many cases, behavioral parenting training is provided through really great evidence-based programs such as Triple P and Incredible Years. And they're often in parent groups. And so the programs can be anywhere from 8 to 16 sessions included. And in primary care, when we see a child for concerns of ADHD, we can do the diagnosis, we can initiate medication, and then we can continue that medication management as appropriate. We can also help the family coordinate services and resources at school. But for school-age children, that parent behavioral training is going to be such an important element of the treatment program. But it's not one that's really easily accessible in the community. And it's not one that is widely provided within the primary care setting. So it requires some outward referral in most cases. The access to these trainings is challenging for parents in general. And then there's also this additional challenge of ensuring that when parents can get access to it, that it's provided in a way that maximizes their engagement. So I'm going to shift a little bit to talk specifically about this parenting training for Black families and how we can optimize these trainings to really help eliminate the disparities and bring equity to ADHD care. So these are some broadly defined parenting styles that have been found to differ generally in terms of use among families by race and ethnicity. And they serve as just an important backdrop or a foundation to our discussion of parenting training for Black families. Now, the authoritarian parenting style, in that style, parents have high behavioral expectations, often utilize more punitive disciplinary strategies. In the permissive parenting style, which is the next bullet, parents have fewer demands or behavioral expectations or limits or restrictions on the child. And then the authoritative style has been defined as really the balance between the authoritarian and permissive. And so it's a balance between appropriate behavioral expectations and responsiveness to the child. And researchers have found that on average, Black parents are more likely than white to use an authoritarian style. So the general conclusion in the literature from various studies is that the authoritative style is the most effective form of parenting in terms of positive child behavioral outcomes. There is also data from studies of Black families that challenge that assumption, but I'm not going to really have time to go through those here today. Much of parenting training for ADHD focuses on strategies that do emphasize that authoritative parenting style. And those are things like labeled praise for compliant behavior in children, non-physical discipline strategies for non-compliance, and then ignoring negative behavior and focusing on the positive behaviors. So that's the foundation. And then how can we provide these evidence-based behavioral parenting training strategies to Black families that's also within our historical and our social political context of really what it means to parent an African-American child in the United States. And I'm going to discuss 3 elements of this for a behavioral parenting training. I'll talk about understanding the context of parenting for Black families in the United States. Then we'll talk about strategies to adjust that content to meet parents' needs, and then how we can also adapt the format to have better access for families. So starting with understanding the context. We have to come to families with an understanding of what even is the context of parenting a child in Black families. And so this historical context, it starts in slavery. It goes through Jim Crow, through the Civil Rights Movement, and through the present day and the challenges we continue to face. Through all these years and all this history, to our current societal realities, Black parents continue to be faced with the challenges of preparing their Black children to endure racism and unfair treatment in our society. So starting back, I want to talk about slavery. During slavery, children made up a substantial proportion of the Africans who were forced into slavery in the United States. Now, before 1865, 12.5 million Africans were brought to the New World on ships. Nearly a quarter were children. And that was defined in the U.S. slave industry as a person under the height of 4'4". The average African who was stolen into the slave trade was a teenager to a young adult. But as the Emancipation Proclamation came closer and closer, younger and younger Africans were forced into the slave trade in the United States, down to the average age towards those last years of 9 to 12 years old, when it was clear that abolition of the slave trade was imminent and coming. So in this U.S. industry of slavery, slaves were not allowed, of course, to maintain any of their culture, and thus the parenting practices of West African cultures where most slaves came from were lost. Children as slaves were purely a commodity. Like any other slave in the slave industry, they were subjugated to all the horrors of slavery, including brutal violence, separation of families, sexual assault, and rape. Parents who were slaves had no authority over their own children, and in many cases had to watch them suffer this kind of repeated abuse from slave owners and overseers, or worse, have those children sold away or be sold away themselves. These are some photos from the collection of the Smithsonian National Museum of African American History and Culture. And they show a photo of women here. I'm using, hopefully you can see my cursor. Women and children in the cotton fields in the 1860s. Here, we see a photo titled "Gordon Under Medical Inspection" of an escaped slave, which fueled the abolitionist movement. And then here, we see a photo of a child's iron shackles. Now, when slavery ended, the injustices that awaited young African-American children did not end. Black parents continue to have the need to teach their children how to show complete reverence and compliance to white people in public. as any deviation from what white people viewed as appropriate behavior for a Black person or child could lead to severe consequences. These photos are also from the Smithsonian National Museum of African American History and Culture, and they depict this struggle. At the top, my top left, we see if I'll put my cursor here. Here, we see Black children standing outside of an Arkansas school awaiting instructions from a teacher to register for school as school desegregation occurred. Right below, we can imagine the instructions that Mamie Bradley Till, Emmett Till's mother, gave to him as he prepared to leave his home in Chicago to visit his family in Mississippi for the summer. How do you prepare a 14-year-old boy to display behavior that white people would need to interpret as perfect reverence to their position in society? You cannot. Emmett Till was lynched in Mississippi in 1955 at the age of 14. During this trip that he took to visit his family in Mississippi, he went to the store with his cousins and some friends to get candy, and a white woman in the store accused him of wolf whistling at her on the way out of the store. Years later, she admitted that she made that story up. But for that perceived slight, Emmett Till was kidnapped, brutally beaten, and murdered at the age of 14. An all-white jury acquitted the white men of his murder. And he's pictured here with his mother, who courageously had his body, which was mutilated, displayed for the world to see in an open casket funeral in Chicago, which sparked the next phase of the civil rights movement. And then pictured here is a pamphlet that published the International Labor Defense, by the International Labor Defense. And it shows a photograph of men marching in support of the Scottsboro Boys. Now, the Scottsboro Boys were 9 Black teenagers ranging from the ages of 13 to 20 who were falsely accused in Alabama of raping 2 white women in 1931. The case was heard in Scottsboro, Alabama, and included a lynch mob. So starting in slavery all the way to Jim Crow to today, Black parents have to teach their children to deal with the brutal realities of racism from a very young age. Now, the parenting style of authoritarian was not a choice, but many times, as you can imagine, is a matter of life and death. And sadly, we see that this need for Black parents to instill this complete, immediate, and unquestioned compliance in the face of white authority has persisted in this country to our present day. I'm sure most of you have seen the trial for Derek Chauvin and the conviction, or the findings, the guilty verdict. But I want to talk also about, we're not there, right? So there are Black children and youth who have been killed by a police officer. And I'm going to name these children here from the top row, left to right, and then I'll go from the bottom, also left to right of the screen. So first, Kwame Jones, 17, in 2020 was shot by police at a traffic stop. This is we have Kendrick McDade, age 19, was shot dead by police officers in Pasadena in 2012. They were looking for a thief who stole a backpack, and he was not the thief. Tamir Rice, you may have remembered seeing that video of when he was killed. He was age 12. He was killed by a police officer in 2014. And he was at a park playing with a toy gun that had, at the park by himself playing with a toy gun, the orange tip barrel. A woman nearby called the police complaining that a Black male had a gun at the park. And if you've seen the video, when the police drove up to Tamir at the park, they immediately stepped out of the car and shot him with no hesitation. He was 12 years old, playing by himself at the park. He and his family have not had their day in court. Jordan Edwards is a 15-year-old boy who was shot by a police officer. Laquan McDonald and shot in 2014. Devon Bailey, shot in the back by police in 2019 at age 19. Cameron Tillman was 14 years old. He was a high school freshman, and he was shot by police while he was hanging out with friends after school. He was at an empty house that his friends used as an after-school hangout with the owner's permission. The police knocked on the door in response to a disturbance. Cameron opened it and was immediately shot dead. And then Detrick Griffin, age 18, shot in 2019 by police. So once we are able to come to Black parents with a clear understanding that there is a historical context around parenting Black children, then our next step is really being able to adjust that content of our parent behavioral training. And this can be done in several ways, and there's various programs that have already made adjustments, adaptations to parenting training groups to really better meet those needs of Black families. A couple years ago, my husband and I, maybe more than a couple years ago, took ADHD parenting training group for our own children. And although as a pediatrician, intellectually, I knew the content and the concepts of behavioral parenting training. It really wasn't until I was in the class after a few sessions, and the instructor showed a video of a Black mother and a Black child using these techniques, and that I emotionally then understood the concepts and the content. And the example is it was a Black mother and her daughter, and it was in the morning, and the child received a consequence for something, some non-compliant behavior, and was complaining and trying to get out of the consequence, and was also in the morning trying to get ready for school and brushing her teeth, and yelled at the mom and said, "I hate you, I hate this." And the mom was cool and collected, did not allow herself to be escalated, but continued with that consequence despite the child's attempts to escalate the situation. And that had been described to me, and I understood it, but I really needed to see a Black mother doing it for a Black child to emotionally be able to say, I think that that's something that I can do. And then the third piece is adapting the format. There are multiple mobile options that we can use for tools that are more familiar with communities who need these types of parenting behavioral training. So it's difficult for many families to make it to an evening session, 8 evening sessions over 2 months in a group in person. And I think one thing that we have learned with COVID is that, yes, we can do some of this stuff virtually. We can do it on Zoom. Maybe people can join in on their phone. So that is something that kind of a silver lining. It's hard to think about how there is a silver lining with COVID, but that is some piece of it that these virtual options are there and they can work too. When we get back to in-person stuff after, we get through this pandemic and we want to be back in person, can we think about non-clinical locations? So maybe families don't want to come to the hospital all the time for a visit. Maybe there are community locations where they can be in a group in a location that's more convenient and familiar to them, and in a group where they have other people in their community with the same concerns and the same lived experiences and learn from them. And so those are those culturally relevant groups where families can connect with other families that are in their community and share their experiences. So I've got about just under 10 minutes left, and I want to talk a little bit about this last topic. What do we know about the disparities, and what are the other factors that I haven't talked about that might lead to inequities in care? And there's really quite a bit of great data on this. The vast majority of studies really looking at disparities illustrate that Black and Latinx children are less likely to receive a diagnosis of ADHD, and then they're less likely taking a medication for ADHD when we compare it with white children. Now, the studies that support these findings are summarized in these boxes here. These are studies that really focus on national data, some multi-state data, the National Survey of Children's Health, the Medical Expenditures Panel Survey, National Health Interview Survey. There's an Early Childhood Longitudinal Cohort Study. We have state Medicaid data, and then Healthy Passages Longitudinal Study. And in case you're interested in reading those, their citations are right there below on the slide. Now, there's been a few studies that have not found the disparity in diagnosis or medication use by race and ethnicity. And these are studies that use data from NHANES, or the National Health and Nutrition Examination Survey, and then the redesigned National Survey of Children's Health. The NHANES study, those differences, they may relate to such factors like the relative distribution of white versus non-white participants in the study, the breadth of socioeconomic covariates included in the adjusted analysis. The 2016 redesigned National Survey of Children's Health also did not find the disparity in that last iteration. So the previous iterations of the National Survey used a phone survey methodology, and analyses of those studies did find the disparity. In 2016, this is the first time that the National Survey used a completely online and mail-based data collection system. It did have a 40% response rate, which is not bad really for national surveys at all. In fact, pretty good. The sample population responded via mail and online. And that population may be very different than the population that responds via telephone. So as further studies come out, we'll be able to see what that looks like as we move on. So I want to talk a little bit about a few other factors. What is the influence of racism, discrimination on mental health? This is a study we did back in 2009 with my team and colleagues. And we found that Black and Latinx children with perceived racial ethnic discrimination by self-report were more likely to have symptoms of ADHD, depression, ODD, and CD, conduct disorder. And this association did not exist for white children. So in addition to sort of just a cultural context of racism in the United States, the actual personal experience of racism and discrimination potentially is an important factor as well. Trust is another factor that's really important. Heard a lot about trust, I think, in the media when it comes to COVID. We know from multiple studies that Black parents, even when we control for other factors, have lower levels of trust in their providers than white parents do. And that's probably multifactorial. You can think of some of those factors are, one, just what we know about the historical and present day context, right? We see studies of that show a bias in the way that Black children in particular and Black adults are treated in the healthcare system compared to white. It is directly related to racial bias. And then there's also this element that Black families are not going to have that concordance or that shared lived experience with their provider as often as white families do. Studies have shown that Black adults are more likely than white to report lower levels of trust in their providers as well. And then trust is also low among adults who receive care in settings with low provider continuity. So that's an important factor that really being able to have that relationship with a primary care provider is really important in terms of trust. And then treatment engagement is also another important factor. So state Medicaid data from 9 states from 2008 to 11, over 170,000 children initiating treatment. The researchers found that when compared with white children, Black and Latinx children were more likely to discontinue medication and more likely to disengage from treatment. And many of the factors that we've already discussed may be factors in that disengagement. So I'm going to wrap everything up in the next couple minutes on this summary slide here, really focusing on that initial question that we started with. What is the potential impact of ADHD disparities in care? So if we start from the top of this funnel, we know that from research that early childhood experiences and other environmental influences can have a profound impact on child and adolescent developmental trajectories and even eventual adult health outcomes. Now, behavioral and mental health problems in childhood can also be exacerbated by these same experiences and influences, racism, poverty, and the related stressors of both. It may not be, of course, that these stressors are directly causing ADHD, right? That's not it at all. It is the stressors perhaps can exacerbate the behavioral problems as well as a parent's ability to support their children during them. At that next level down on the pyramid, the inverted pyramid, we see that there inadequate clinical intervention for Black and Latinx children. This, of course, is multifactorial, but the disparities on the healthcare end that we discussed, diagnosis, treatment of Black and Latinx children compared with concerns of poor access to mental health care, lower levels of trust in providers from communities of color due to historical trauma, and then these all collide to an overall inadequate clinical intervention for ADHD in Black and Latinx children. And then finally, we can taking into account behavioral and mental health problems, inadequate intervention for ADHD. What is the potential impact on child health and well-being? So the behavioral problems in Black and Latinx children are often interpreted differently in schools, more likely to result in harsh punishment at schools. So for children of color, this inadequate treatment for ADHD that we've described, when they have these problem behaviors, can and will have serious consequences at school that will have a negative impact on their health and well-being unless we really change our paradigm for treatment. All right, I'm going to leave it there. I feel like it's weird to just talk and not hear anything on the other end. So I'm excited to really see what questions you have and have a little bit of a discussion.
Okay. That was excellent. A lot of good questions as usual. One parent wants to know, her child is in the mid to late teenage years, and she wants to know if the behavioral parental training it's too late for him to benefit from it.
Looks like you're muted, Dr. Coker.
Did you say middle-aged teenagers? I didn't quite.
Yeah, mid to late teenage years. She wants to know if BPT could be used to help her.
I think it could be. When kids get into the late teenage years, the behavioral treatment does shift a bit towards helping that later age teenager be able to have some strategies that they can use in terms of either organization, particularly strategies for academics for themselves. And that is kind of, so they might be in those sessions on their own. There are, for that age group also, the sessions that include the kind of later age teenager with the parent. And then in terms of just plain old behavioral parenting training, I do think that my kids we did it when they were already teenagers, kind of early teenage. But for sure teenagers. And so I think there are strategies that still are helpful. I really do. Strategies on how to just deal with conflict at home. I think we spend a lot of time in particularly primary care dealing with ADHD and focusing on the school behavior and how to help that child perform well in the academic atmosphere and get homework done. But then there's this whole other kind of household. How does a household structure? How what is a disruption in the household that ADHD is bringing into the household, and how is that the family functioning? And so that's where I think that the parenting behavior treatment or training can really help, even when the child is older and maybe doing some of those interventions on their own for strategies that they need personally. But then that parent, you still have to figure out, outside of the academic needs, outside of getting homework done, how is the family functioning? And that, I think, is something that most parents, as long as their child is really there, can use some help with.
Mm-hmm. Do ADHD coaches have a role in helping with helping get through the various challenges, or is it medication? I mean, are they part of the treatment plan?
I think that they should be. I think in many cases, they need to think about the way our healthcare system is set up, and as primary care, we may not, like when you say ADHD coach, that could be a lot, that could mean a lot of different things. But, you know, let's say you have a parent to parent, like a peer ADHD coach. Uh-huh. So, you know, there are people who could be part of that treatment team, especially when we're thinking about equity, right? And so if we know that we don't have our representation for Black and Latinx children in our healthcare system in terms of providers. But what about the larger team that takes care of that family? There are community health workers, there are coaches, there are health educators. You don't necessarily have to have a PhD or an MD to know how to help a family with ADHD. So I think the parents need more than just their provider and just a specialty provider, just that professional psychologist, right? They need a team. And as much as we can provide that team and include people like coaches on that team, yes, I think that all that can have an impact on families. Just more touch points, more communication, more access. But all that being said, most providers don't have that benefit of having other people on their team besides the people who are the main providers of care. So I think that's a kind of different paradigm shift that we need to see in particularly in primary care in general, but really in ADHD care. How can we kind of flip the script and get out of our usual way of saying, oh, you can only do this particular training if you have PhD level interventionists, but who else can be able to provide that service and can add to that team? So I think it's really important. I just don't think we do enough of it.
Yeah, right. Several people have asked about trauma's link to ADHD. You talked about adverse childhood experiences. Could you talk a little about that? Might a child who a clinician thinks has ADHD really have trauma?
So I think it's a really important issue. I don't think there's always a either or, right? You can obviously have ADHD and trauma. You can have trauma that looks like, and the behaviors look like ADHD. And so you can do, it can look very different for children in really different times, right, of their lives. So I think that goes to really taking care in that initial diagnosis, getting a full history, because if we don't know really a good history, we don't really know how to treat the child. I think that's also the importance. It kind of speaks the importance of having a really that primary care relationship with a primary care provider. So as a primary care provider, I don't want to say, oh, there's a problem in school, there's some inattention, let's just call it ADHD and start the medication. That is really not even the guidelines when you think about we have guidelines for treatment, diagnosis, and treatment. So really being able to get the information from the teachers, from the parents, and then have the history from the provider, getting from the parent and the child. So we need to have a big picture of reports from different individuals and parents, how the child's doing at home, school, and then right there, the history I'm taking in the office or the clinic. And then really being able to understand what other social needs that the families have. I think even when there is a diagnosis, we make a diagnosis in the midst of doing it in a trauma-informed way, knowing that the child has some trauma exposure. We still have to be cognizant that when that is ongoing or there are social needs that are ongoing, it's going to be hard for the family to really make that investment in the behavioral changes at home, particularly around parenting, when they've got these social needs stressors that are just, clouding everything.
Right.
So I think that is why there is a real importance of thinking about this from more of a holistic way in the primary care setting. Yes, I have this child has ADHD, is experiencing and has experienced trauma, and the family has all these social needs. How can we make sure that we address all of it, right? We can't just ignore the social needs, because all the stuff that we're trying to get the parent to be able to learn in terms of parenting training, no, you can't hear that when you're living in your car, right? Or when you're afraid that you're going to be evicted, or when you're maybe not even at home because you're an essential worker and your child's at home on the screen and you have to be at work all during the day. So there's so many different pieces, but we can't lose sight of just what it's like and what's a family household functioning and what services do that family need for that, so that then they can pay attention to the issues around ADHD.
Mm-hmm. What are the suspected reasons for Black and Latinx children discontinuing medication?
Right. So that's a question I think about that treatment engagement study that the person is perhaps asking about.
Yeah.
I think really what we talked about. So the one piece is you're talking about disengaging on medication treatment. That's why our guidelines really tell us we have to keep bringing the families in and really close follow-up, particularly in the beginning, even closer follow-up to find out how they are doing on side effects. Sometimes it might take many pieces before we get that right medication. And if the family is not prepared for understanding what that process looks like, they start one medication, the child has side effects, maybe can't fall asleep at night or is not hungry enough during the day, and they just say, forget it, I don't want to do this. These side effects are terrible. But really having that relationship with the provider ahead of time and having that discussion, these are the potential side effects. Our goal is to get the right dose without while minimizing the side effects. We may not get it right on the first time, so we have to keep trying until we get it right. And I'm going to keep trying until we get it right? And knowing that. So that's that trust, too, that only comes from a relationship when the parent knows, yes, these are side effects, but I've already talked to my provider, and I know that we're going to continue this, and I can get in to see them. I don't have to just live with this and then decide to stop it on my own. So I think that's one piece that's specific for medication. Mm-hmm. I think the larger picture is just going back to that trusting relationship with the provider that's continuous and over time, and figuring out, are there other things going on, going back to those social needs that make it hard for the family, the child, the parent to really have that full treatment engagement. Mm-hmm. Because of other things that are happening, other stressors that they are dealing with. How we deal with those stressors and then maybe get that treatment engagement as well.
Right. Are there any training programs, national, state, probably local, about educating clinicians about the context you just gave about racism and ADHD? And the same goes for teachers, school administrations with the suspensions and misinterpreting behaviors.
Right.
Is there anything, any programs or training that, or is this done really on a local basis, that clinicians and teachers can access to sort of educate themselves about this?
Right. So it's a great question. I think, I'm not sure on the school side, the education side. On the provider side, in the slides, I have citations for all the papers that I have cited. There's a website that's specific towards Black families and parenting, which I really like, which I encourage you to take a look at. It has.
Which one is that? I'm sorry.
It's in the slides when I talk about parenting. So those are some, I think, a lot of the stuff that we talked about just on that's not related to racism and kind of the historical context. We have really great and specific guidelines, and as well as screening tools available through the American Academy of Pediatrics on that site. And I think, as you know, there are lots of in our literature for the clinician perspective, lots of papers on disparities, racial and ethnic disparities in ADHD. And then from kind of a parent perspective, I think that website for Black parenting is really helpful. And I'm not really familiar with what's available specifically for teachers, but that's a great thing to look into and an important question to really figure out that piece of, why are kids getting suspended and expelled and having these harsh disciplinary pieces. Schools may be doing implicit bias training, EDI training for their teachers and staff to help give a different perspective and hopefully bring that down. Right. And I know the other piece is that there is a push for to end these harsh disciplinary strategies in schools, so that if you don't make it available, then people cannot use it, and then it won't be used more in Black children. So I think that is probably the answer, and just not allowing. You can't expel a preschooler. Mm-hmm. Right. I mean, most people are going to be in agreement with that, and so those are just kind of policies I think that need to be in place.
Right.
And the no police, that police officers should not be involved in school discipline, right? Right. It boggles the mind that a child would be put into the justice system for any slight at school or behavior, we have to separate our education system from our juvenile justice system. And there's no child should be put into the juvenile justice system for what they do at school. Those are policies, I think, that are probably even more important at the school system than training resources, and just not allowing that to happen at all. And some school districts are moving that way or have moved that way.
Mm-hmm. Just quickly, because several people have asked it, and I know we're running out of time here, is there a directory or some website where people can access the various BPT programs out there?
I would say the websites for the programs. So I think from a provider perspective, I've listed a few of them in the slides. Mm-hmm. So you look at Triple P, they have their own website, Incredible Years, and there are others. I believe the AAP website likely has a resource list for training programs as well. And then from a parent perspective, a good place to start is, likely with your primary care provider. So if you have a child that's on medication but not having any behavioral treatment, and you haven't had some or that training, I highly recommend it. I'll just say really quick, it changed our life as a family in terms of dealing with my two boys. So ask your provider, and if they don't have resources, you can start with those. And they're available online, actually. There's like an online version. Some of them have a cost to them. So that's can be a barrier for many families. Right. But most places will have some referral source to get those trainings. It's just a matter of getting that referral. And I think ideally we would be providing it ourselves in primary care. And that's really what I'm looking forward to happening.
Okay. Well, I think the hour is up.
Okay.
Thanks so much for being here and sharing your insights. It was excellent. Really appreciate you being here today.
Okay. Thank you, everyone. Have a wonderful day and be well.
Okay. And you too. And thanks to all of the attendees for joining us. Please join us next week on May 6th when Miriam Saunders will talk about managing problem behaviors in children with ADHD. And finally, make sure you don't miss future ADDitude webinars, ADHD expert articles, or important research updates by signing up to receive our free email newsletters at additudemag.com/newsletters. Thanks everyone for being here.